and lots of other friends across the data community talking about data, health, innovation to save lives. Today we've got the usual run through. We've got 3 people giving us some talks. We've got a request for some support by Nick Garrett, who I can see there. James is on the line, James Tozer from The Economist. He's going to tell us what he's talking about, but I guess he's going to be talking about his the code that he's put online and the data they've been doing. We've got Alistair Bullward from NHS Digital, who's going to give us an update on what NHS Digital are doing with open data, and I guess the amplification of all the publication that's requested. So I'm really interested to see what Alice is going to be talking about. And the ODI Leeds team are going to do is a piece on open data practice, show you some of the tools we've built, some of the open data hints and tips that we've got, and also just to keep people ticking along and what people can do with open data. So I'm going to put myself on mute for a couple of minutes and get myself a coffee, and we'll look to start between now and 5 past as people join in. I was just thinking we should really have some intermission music as people join, shouldn't we? As everyone joins the waiting room. Maybe we can take a. If you put some suggestions in the chat, we'll see if we can link. Oh yes, Nick's trumpet. So we could do a band, couldn't we? We could have Giles on bass, Nick on trumpet. Yeah. Oh yeah, acoustic guitar. Nick on his trumpet. Mark Fowler's the lead singer.
Sadly, I don't have my piano with me here today.
Oh yeah, Amy's piano. So yeah, that's I can do about tambourine. Yeah, that would be good. Yeah, Liam played a good tambourine, didn't he? So that would be perfect. So again, yeah, welcome everyone to Open Data Saves Lives. We've got 25 people signed up new this week on Eventbrite. We've got 50 people on our mailing list who may or may not join us, but have joined us before. And we're just waiting people to join through the Zoom waiting room. So lots of people keep joining, which is great. The aim of today is to try and get finished in 45 minutes. Hopefully, there's no reason why things need to last an hour on a video. Just for some reason, just because we're on a video call, it must last an hour. So we're going to try and aim to finish under the hour. We've got Nick Garrett's going to ask us for some help. We're going to get him at the start of the top of the shop. The Google document there with the agenda is in the chat. If you need to find out about anything, Amy, could you put the Open Data Saves Lives page on the chat as well, so people can see what we're doing. We've got 3 talks today. We've got James Tozer from The Economist, who's going to tell us about the work they've been doing, and also the code that they released openly, and what they would like us to do with it. I guess that would be amazing. We've got, if I can see him, I think I saw Alistair Bullward from NHS Digital. Hi, Alistair. You're going to tell us what's been going on at NHS Digital. I guess there's quite a lot happening, and let us know what data is being published, what the pipeline is, and what help you need from us. Because I think right at the start we gave you some good use cases, and we gave some feedback on the platform, and it'd be good to check in and help with that. And then the ODI Leeds team are going to go through some open data practice work. So we've done quite a lot on creating tools to help people use, publish open data, and a lot of that has come through people have told us they can't do it for a reason, and then we've gone off and fixed that reason, so there's no reason why they can't publish. So some CSV cleaning tools, some help publishing to JSON, hints and tips on what to do. Stuart's still on the line. We don't need longitude and latitude to the to 15 decimal places on each atom located on a map. So I'm just filling here if you didn't realise. So we're at 11:04. At 11:05 we're going to start. And then if you've got any questions or queries or points or things you want to share, if you put them in the chat, and we'll either pick them up if they're relevant during the talks, and we'll get the people giving us an update to fill in on that, or we will pick them up at the end, and we'll stick them in the Google Doc. We'll capture the chat. And just to let everyone know, we are recording these sessions, so if you would not like yourself to be on the interwebs in the future, let us know and we'll edit that out. But hopefully, as you've joined Open Data Saves Lives, you get that this probably will be on the web, and anyone can use, share, reuse, remix what we're all doing here. So 11:05, we're going to start. I'm Paul Connell from ODI Leeds. You can check the ODI Leeds teams with their Open Data Saves Lives backgrounds. If you want an Open Data Saves Lives t-shirt, we're putting them on sale, and also our cool Radically Open pink t-shirts as well. They're going to go on sale as well. So get always with the merch. So first up, Nick Garrett, tell us who you are, where you're coming from, and what help you need. Then we're going to go to James, then Alistair, and then Patrick Lake of ODI Leeds. Over to you, Nick.
Thanks very much, Paul and everyone, and good morning. So I'm interested in qualitative data from residents or citizens that gives insight to do service design for my organisation. I'm just going to share my screen, if that's okay. Just take you through a few bits. So I set up Knaresborough Connectors 18 months ago doing social prescribing. There's 16,500 people in Knaresborough. It's a strong community. We had about 25 people doing a community connector, asset-based sort of social prescribing role, working with community groups and societies. Then following the virus appearing, we turned into a community support organisation authorised by North Yorkshire County Council to provide the following sort of service to people, and then we grew to 130, from 25 to 135 people across the town who sought out neighbours with those services. We've had about 425 unique contacts over the past month or so, and once you're matched to a neighbour, your neighbour then helps you out, and we don't really kind of hear from you again unless you run into further difficulties. So we've been doing that during lockdown. But the challenge is, I suppose, is how do we ensure we continue to meet the needs of this town and surrounding villages, and crucially, how do we bring people with us on this development, making sure that we include people who actually we've really struggled to reach. So some of the data I'm hoping we might be able to help us find is data really that gives us insight to do service design and create meaningful projects. So moving from being a reactive service-based organisation to one that's going to set up specific projects in our town to make a difference to people's lives. So the bottom black box is key there, which is insight to do service design. Now we've had an engagement event with 40 people from across the town on a Zoom call, and I'll show you how we did that in a second. But what we recognise is that there's a layer of people and residents and groups that are just really hard for us to engage with during lockdown. And we need to understand the risks and strengths of those groups, and particularly risks and strengths from children and young people in terms of what they're facing during lockdown. So we're after qualitative data, hopefully from elsewhere, to use as proxy data where we've got gaps. So we have gaps with that middle tranche there, care leavers all the way down to adults with learning disabilities. And the type of questions we've been asking residents so far are, what are the challenges during lockdown and beyond for you and your families? What can you offer? How are you feeling? It's important for us to know that so we can plan projects and put things in place to support people. But that middle layer is really, really hard for us to engage with. And we're wondering if there's any qualitative data from other parts of the UK. Knaresborough's not massively different to other areas. And actually, when you're in lockdown in Knaresborough, it can't be that much different to lockdown in maybe Wigan or elsewhere. So we're wanting to see if we can use data as proxy data where we've got gaps, and if there's any comparative data to back up what local people are saying. That strengthens the sort of business case for the projects that we're doing. Just to show you then what we've done so far, we did an engagement event on Zoom, and what we did is we took people through the effect of the epidemic, so showed them a few stats. We told them that the Harrogate district in Knaresborough has a higher than average number of people in moderate to high risk groups. You see the whole systems partnership on there. That's who I actually work for when I'm not running Knaresborough Connectors. I think some of you may remember Sarah Overton from Kent CCG coming on the call. She works with Mark Farr, and some of our work was put on there. But obviously, we're using everything within our capabilities in Knaresborough on to support the Knaresborough Connectors. We took them through what, if we'd done nothing in terms of social distancing, and then what we did is we showed them 5 different household types, and those household types are based on ONS stats, but I kind of adapted it slightly because, as you might imagine, there aren't many multicultural metropolitans in Knaresborough. I'm probably the only one in a challenged Asian terrace. So we came up with a kind of classification based on this ONS statistics for household types. I'll very quickly take you through them just to show you what we've done, because it highlights where we've got gaps. So suburban achievers, constrained flat dwellers, ageing town dwellers, squeeze middle, although some of them haven't got squeeze middles, hard pressed living. And for each of those classification types on a Zoom call, we use something called Mentimeter. So I thought I'd just share that, actually, because it might be quite useful to other people. We use mentimeter.com. So I don't know if other people on the call have used this, but essentially the way that you do it is you go on the Mentimeter website on your phone, you enter a code, and when you're asked a question, what has this household got to offer, you type in your answers, and it all forms a word cloud that everybody could see. There's quite a quick way of actually getting, for each household type, what they've got to offer and what are the risks. So we've got a reasonable amount of data from 40 people across the town, and those 40 people are quite informed. They work in charities, they volunteer already, they're maybe members of churches and things like that. So they're running community groups, these people, so they have a reasonably good understanding for all these households. But where I'm struggling, I suppose, is getting this sort of qualitative data from care leavers, kids in care, hard-pressed living households, teenagers 18 to 25, and adults with learning disabilities. Now, I could try harder to go and find that myself in my town, but it's really, really hard. So I'm just interested if there's any data out there that covers some of those hard to reach categories that we can use then to build some really interesting projects to solve some of these wicked problems that we're going to be facing, particularly because we think there's probably going to be a second wave. So thank you very much. And just so you know as well, the other things that we've done is we shamelessly copied ODI in putting a Google Doc open for people to contribute to, and that's been really successful. So I want to say huge thanks to Paul and Amy and the team for inspiring me to do that and continue to try and be really, really open in what we're doing. So thank you very much.
Fantastic. Radically open. So thanks, Nick.
Cheers.
I think that's a request for help.
Yeah.
I think from there may be some people on the line. There's people with the same experience. I think we will pick that up and try and share that as widely as possible. I think maybe if you want to talk to Amy, we can put a case study up on the Open Data Saves Lives website so that people can see that, and you can demonstrate what you're doing, but also where you need help. I'm pretty sure Alistair at NHS Digital, there'll be data coming through from that. And these difficult questions are something that's going to be really important. But I guess what you're looking at is feedback, so you can design a service that is better when you set off, rather than learning as you go and 6 months down the line realise that you may have done that better. So,
yeah.
And if we do that collectively and openly, we'll all learn much quicker. So. I think
registered in the request for help, Paul. Sorry to interrupt you, but
yeah.
ODI have the request for help Google Doc. All my details are in there, So please do go on that and look at the other requests of mine and see if you can help out.
Very good. Yeah, Peter's got a link in the chat, and I think we'll amplify that request and we'll put it as wide as possible, because as you say, you won't be the only person who's looking at this. Okay, so right, we've got through this, but what happens next? And all those people that do need more help. I would say that maybe when we talk to the Red Cross, their vulnerability index and what they're doing there, I think there's a crossover there. So maybe there's some follow-up. And I know that people at Leeds City Council were looking at how they apply the Red Cross Vulnerability Index, and there will be people doing that across the country. So watch this space. So that's a really good use case. Thanks very much, Nick. Questions are in the thing. And the next up is James Tozer, the economist. Over to you, James.
Hi, morning everyone. So I'm just going to share my screen quickly. Can everyone see my screen?
It's a blank screen.
Hang on, it's giving me the whiteboard thing. I don't want to do the whiteboard. I want to do this. Can you see my screen now?
Data, yes.
Great. So I thought first I'd start off by explaining what I've done. So as part of my work at The Economist, I've built the first open database that publishes excess death data across countries and for regions within countries. So we've got, I think, 21 countries on there now on our GitHub repo, and for every country and for regions within those countries, we have the total number of people who died for every week going back to 2015. We use that to make an average of the number of people who died in each week of the year, and then to calculate the expected and then excess deaths that have occurred. So I've just pulled up an example for Britain here, which is using the ONS data, and you can go into, for any region, you can go into the number of people who've died, and we've also included the number of official COVID deaths. So for all of these countries and for many regions in those countries, you can compare how the excess death data is comparing to the COVID deaths, and therefore which countries might be doing a better job in terms of tracking what's going on in terms of deaths. And also the other thing that we're hoping to quantify going forwards is what share, that in most places there's a gap between the number of people they officially say have died and the excess deaths, and we're trying to work out what share of that gap can be explained by people who have died of other things who might usually have been treated. So fewer people showing up to hospitals for treatment for heart disease, for strokes, and there's some evidence from Scotland as well that there are an increasing number of deaths from dementia. But yeah, so this is what we've built. Is this database? So you can go in and search for any country, and we'll keep it updated. There are a couple of other people who are starting to publish this as well. I think one of the nice things that we've got that sets it apart slightly is that we've published all the underlying source code as well. So you can go through and see for every country where exactly we're pulling the data in from, which is quite involved. And then you can go in, there's I think it's about 1,300 lines of R code in here that goes through in painstaking detail how we do this for every country. So if you want to check exactly how it's done, you can find it all commented up there. So part of the reason we did this, we started doing this back in March because we spotted in a few places, particularly in Spain and Italy, you could see that there were far more deaths, sort of excess deaths being recorded than official deaths. So we started working on it back then, and we were the first, I think, English speaking publication to show this. And then we were also the first to launch an interactive tracker. So this, for every country that we have, or actually this is just for the 10 that we published at the time, we have sort of interactive charts so you can go through and track what's going on, and with subnational regions as well. So hopefully the idea is hopefully it can be a useful resource for researchers who want to, because I think particularly for research about policy effectiveness, if you want to see whether particular kinds of lockdown or testing or tracing is effective, what you really want to be doing is looking at, you want a comparable measure across countries, and obviously official death tolls are accurate, and more accurate in some than others. So we're hoping this will be a useful tool for researchers because they can get a consistent data set across countries. And the other thing is that most of the countries that we've tracked this for are developed countries, so they're almost all in Europe. We've got some data for the United States as well, and a couple in South America. And we've also got some data on burials from Indonesia, which shows much higher excess than the official toll reports. So our guess is that in many developing countries, so we're thinking in particular the subcontinent, so India, Bangladesh, Pakistan, and Africa, you'll see probably much higher excess deaths than official deaths, just because the latter relies heavily on testing, and the testing capabilities there are less than in Europe and in North America. So going forward, we're hoping to gather as much data as we can from around the world, and if anyone spots anything that we've missed for any countries that have started publishing this, it's always really useful to be pointed towards new data sets. So if anyone spots anything, I'm all ears.
Fantastic. Thanks, James. You say you've published can you just go through the nuts and bolts of where you've published the code? Sure. How that's working? Yeah.
So the code and the data is published on The Economist's GitHub account, and there's this publicly available repository, and I can send the address around afterwards, but it's The Economist /COVID-19 excess death tracker. We've got all the source data, so I've spent the last 5 weeks working through various sort of governmental PDFs and unwieldy spreadsheets and stuff, so you can go in if you want to see the old, for any country, you can go and see these enormous, I'm not sure that, GitHub will show these, but so it's got all the source data as well, so if you want to go and inspect that, you can have a look. And the code basically takes in all of these files and formats them into a consistent format across countries, so that if you want to do comparative analysis, you can. But the nice thing now is the code has taken most of the workload off me. It's spent a lot of time building it, but now it's much easier to maintain, thankfully. But yeah, it's all there if you want to have a look and get a bit more of a feel for what the underlying data looks like. Then it's all there for you to have a look at.
Fantastic. And just before there's a question in the chat, but what do you think is the biggest question that we need to look at?
I think the biggest one is the availability of this in outside of Europe and America. I think this is going to be absolutely crucial to have this stuff for understanding how widespread the crisis is in Africa and India. And the unfortunate fact of this is that it's much easier to count the number of people who have died than it is to test and diagnose people. And so my hope is that we might be able to get some of this data in those countries, but it's, they don't have, the reason that we have so much of this data for Europe and America is they have much stronger infrastructure for this, and they report a lot of it on a weekly basis already. So trying to find equivalents for India, Africa, and for places in South America is my top priority right now.
And just for the last question is could you just tell us how the UK compares to the rest of Europe in its data publishing on that?
Sure. So the ONS has, I think, probably the best weekly data of anyone I've seen. It's updated. There's less time lag on that than pretty much anywhere else. So in terms of data availability for the excess death stuff, it's really good. There are for the UK, we've got two types of official death toll. We've got the daily one, which you've all seen on the news and gets read out each night, and I think currently is around 37,000. The ONS also produces a retrospective official toll based on analysis of death certificates, and that's more like 40, I think, at the moment. And our excess deaths overall are approaching, I think they're 55 or 60. So we're missing quite a large, the official death tolls are missing quite a large chunk of what's going on. And when you look at, I think the best examples in Europe are France and Belgium, where their official death tolls, they're including a lot of people in care homes, which is something that we've not done as effectively, and their official death tolls are picking up something like 95% of the excess. So there are definitely countries that are on the official death toll that are doing a better job than we are.
Okay, good. So there's a question in the chat from Mark. Mark, do you want to ask your question yourself?
Yeah, sure. Thanks, Paul. Just a quick question. So we're a big hospital looking at planning our beds for next year through the next calendar year, and a lot of the pressure is on us to, ramp elective activity back up. So we're doing a lot of work modelling COVID regionally, modelling second spikes and next winter and all sorts. And some people think that we'll be less busy next year because we've been extra busy this year.
Sure.
And I just wondered what your take on that was. And then the second question linked to it was if you had any data or view on died from or died with COVID, because that's something we're kind of looking at locally. But perhaps your view on the first one, because it all links to excess deaths.
Sure, absolutely. So we actually published an article about this. There was a paper produced about 3 or 4 weeks ago by some Scottish academics, which looked at comorbidities. Because there is this theory, right, that COVID has largely killed people who are already quite close to dying anyway, and so you're going to see a reduction in excess deaths coming out. Now, this paper sort of disputed that. It found that once you control for age, so COVID is killing disproportionately old people, but within those age brackets, it's not killing the people who die look roughly similar to the rest of the population. So it's not necessarily the case that, there are lots of people with lots of life years left who are dying from this. So that they actually did a specific, they quantified it, and they found that the average years of life left was something like 10 or 11 for those people who died. And so their finding was based, their conclusion is that we're probably unlikely, there are a lot of people who have died who wouldn't have otherwise. So it's not the case that that a lot of vulnerable people have. But to phrase this better, they basically think that there will be probably as many deaths as usual after this. That we're not necessarily going to see a reduction in deaths after. I think there's been a paper which you might have seen since. There's been a paper that's done a more in-depth analysis of comorbidities, and I think it's found that there have been a disproportionate number of people who were previously vulnerable who've died. But my guess is that, if I had to guess on the data that I've seen, is that we might see a small reduction in deaths next year, but I wouldn't expect it to be as big as the increase this year, if you see what I mean. But I can send you those articles if that would be helpful.
Yes, please. That's really, really helpful. Thank you, James.
That'd be amazing. And I think, James, what we might ask you to do is just, we might do a little guest blog for you on the Open Data Saves Lives webpage and link to everything, and that will, if that's okay with you. And then I didn't mention this at the top, but we're looking at doing and I mentioned this to James, the Dutch embassy got in touch last week. We did a combined conference with them called the Northern Lands last year, and they want to do an online version of that focused on health and innovation towards the end of June. So it'd be maybe good to follow up on some of this at that in June. So yeah. Are there any other questions for James as we're going? But it's fascinating work, and as you say, the more we are open with this, the more people can engage with it, and the quicker it can be shared and improved and move forward. And I guess if you do spot any queries in James's code or his data, we can all help him make it the best data and code that he can produce. Okay, thanks very much. John said that India, Ghana, South Africa have got good data systems, so maybe there's a link that we can share with that for James, and then we all get a better version of what James is building. Fantastic. Okay, over to next one, Alistair. If you are ready, over to you. Tell us what you've been up to, and we're all ears.
Sorry, hunting for mute button. Can you hear me now, Paul? Hello?
I was on mute. Yes, we can hear you.
Okay, cool. Hi, everyone. I guess there's a few things been going on open data front. I guess the good news is this morning we published a shielded patient list. So that's gone live at 9:30, including an interactive dashboard. So that's aggregate data for CCG, local authority, for people who've been designated on the shielded patient list by both the clinical algorithm and those added by hospital doctors and GPs. So you can have a look at the trends. There's some quite interesting stuff if you look across the map. So I'll drop the link into chat now. So more than happy to take feedback, really interested in how people might use it and what extra stuff they might need to make it even more useful. I guess just to make people aware, there's a parallel work stream, which I'm now calling SPL Plus, which is where the data is going to be not fully open, but not fully sensitive. So we want to control it and looking at that as providing that to public health professionals, but potentially other user groups as well, right? So interested in thoughts around that. So yeah, so that's, I guess that's been a culmination of the last couple of weeks' work. I mean, I would say big education point in terms of getting data open. I don't know if other organisations have got this challenge, but the legal basis for publishing COVID data is incredibly new, and the process we're kind of working out as we go. So this is the first data set that we published under the new COVID direction, which enables NHS Digital to push out COVID-19 data. So just to give you an idea, we had to review this with the National Data Guardian, the Minister, our independent group, governance group, iGuard, and consulted at least 4 or 5 different organisations. So we're trying to work out how we can move a lot faster on that. It's taken us probably about 3-4 weeks from standing still to getting here. In terms of future stuff, obviously we've got an internal long list of open data that we would like to publish, but we've got a lot of operational stuff that we're doing internally. So obviously actually generating the shielded patient list so we can identify people takes priority over publishing it. Testing data starting to flow now, which is obviously a massive priority as well, and lots of other ad hoc analysis to support sort of insight for Department of Health and various others. Saying that, I think, future open data sets, I mean, informally, and this is no commitment, but we are, going to keep pushing forward, is e-referral data. We want to get that out. So that's all about telling the story about the NHS, challenges about people maybe missing appointments because they don't want to go into hospitals. Are you accumulating what we call clinical debt, which is where, basically people, illness goes undetected for longer, and that's obviously very bad for the person, but also very bad in terms of capacity planning as well. So that's an open data set that we are hoping to release. Informal date, 10th of June, but I'll, keep you all posted. And then we'll obviously update that on a rolling basis. And then the big one that we're just starting to scope out, and again, this is early days, is now the testing data is flowing for Pillar 2, for that stuff that's happening in hospitals and community. Working out what we need to do to make an open, aggregate, anonymous data set for that, which I think would be useful for all range of use, all sorts of use cases. Really interested in use cases there, what people might want from that data, how they might use it, and what they might want to see at an aggregate level. That all helps me build cases to do stuff internally. So that worked quite well for SPL, so please throw stuff at me. And there's lots of other work going on internally about linking deaths data and 111 triage data, which we released a few weeks ago. And various other data sets to look at the momentum of COVID across England. And I'm looking at trying to take a cut of that and push that into the open domain as well. But there's some complications around mapping, but that's ongoing as well. So so I guess there's a lot going on. I'm just really happy we finally got a second data set out now after 111. And we navigated the governance. So hopefully ERS and then testing once we work our way through that. Again, use cases, how people find it valuable, massively helpful for us in terms of shaping what we produce and helping me drive prioritization really. So that's sort of one thing, getting the data out. The other bit, I guess, is our portal. So Jess Aitkins and some fantastic work. I think she's presented wireframes on this before, working with the web team. So we're really focusing on getting some collateral out there that explains how to analyze our data. So we've started building some content. So we've got a draft on how to scrape our website. Not as easy as it should be, but at least, it's hard to fix, but we can tell you how to do it properly. in the best way that we know about, we'll get out there as a sort of a bit of technical guidance. NHS geographies is something we're looking at, because I know that is perplexing. When I spoke to some proteomics folks a couple of weeks ago, that was one of their number one problems. And then also looking at contact, like just an index of all our open data sets, how to link across various areas. So really interested in technical problems that people have got using our data that are kind of solvable. It's just quite complicated. Let's get that into some documentation. We'll stick it on a blog. We'll put it on our website, and just try and build out that community for stuff. Because I think the other thing I would say is obviously with COVID direction, I did have grand plans to sort out our metadata, to maybe sort of sorting out some of our platform side of things. Obviously, money and resources is all focused on COVID, and that's exactly how it should be. So I'm keen to keep sort of pushing tactical stuff. So content and data and a very lightweight sort of portal to bring all that together really is where I'm focusing at the moment. So that's me. So just digital. All comments
Excellent.
welcome, really, Paul.
Thanks very much. So we've not had any comments in the chat, but I'm sure they might arrive in the future. We're constantly looking at what we do next with Open Data Saves Lives. We tentatively thought we're going to have a week off next week after the bank holiday, as all recharge our batteries and get back. But the week after, we were thinking about doing maybe a technical session, maybe around geography. We could do a NHS digital use case session where you could present what you've got, people could come back to you. That might be a good use of our time. So if we say 2 weeks today, we include NHS digital, and we could all feed back on specific use cases for you that you can take back and update. And part of that, we had thought about having a session on geography, because it's harder than it should be. So that'll be quite nice. Use cases of NHS digital data and other use cases that people are using data for, geography, and then maybe one other session, and we have 15 minutes each on that, and rapidly come up. And if we set it up early, so we set it up this week, people could contribute during the period before next week, and then we have a really good session. So that's me filling while people are putting in questions in the chat. So we've got a question from Peter, we've got a question from John. So whilst I've been talking, so Peter, do you want to share your point there?
Okay. Hi, Alistair. Thank you for sharing that. It's really good. Can you hear me?
I can, yes, yeah, coming through. Hi, Peter.
Oh, cool. Hi. So so there's lots of things around the shielded patient list. Obviously, the most important thing is to actually help those patients.
Yeah,
I get that. Fundamentally get that. There's also an interesting second order debate about how the data always needed input from humans to make it better. Not least because patients could say, "I don't want to be shielded. I would like to spend my last days on the beach," for example, as a extreme example. But also the improvement by local places, by GPs, etc. And again, I think that's always necessary. But I'm interested as to how much that happened with the shielded patient list. There's lots of anguished debate in some local government circles, shall we put it that way, which I don't care about. But there's an interesting thing about where the updates happened and how they were driven by. I wonder if I say it's a second order question, because there's an important thing right now to help people. But if that was on the use case list,
it is
about how it was updated.
Yeah, so if you look at the dashboard, if you follow that link, it's an interactive dashboard, you can see the map. Now that is for all patients, broken down by age and gender. So there's two, for people who don't know, there's two ways you can get on the shielded patient list. There's a clinical algorithm that basically looks at what you've been admitted to hospital for, what drugs you're on, etc., and decides if you're in there, or you can be added by a doctor.
Only the good drug.
Yeah, only the quite very powerful stuff. You look at it. So so there's two ways you get it, and so you can get onto it clinically, or you get nominated. So initially it was just clinical, and then I think it was from April people could start adding. Doctors could start nominating patients. There is regional variation there. You look on that map, you'll see it.
It's in there.
Northwest, so that is of all people. What we haven't got on there is broken it down by people identified by the clinical algorithm and which which category they were put into. So congenital heart defect, solid organ transplants, da-di-da-di-da. But that is in SPL Plus. And that is going to be going out to all the public health professionals. So there was concern about disclosure around that, and also about how that aligns with some of the other stuff out there. So the strategy I'm trying to take at the moment is we get whatever we can out publicly quickly, which is challenging, and then we've got a controlled version which will break that down into disease groups. And it's if you look at I don't think I'm saying anything I shouldn't. It varies. What's driving the increase. Some of it's clinical, some of it's people nominating. And if you go and hit the HSJ and stuff, you'll see certain areas have been more proactive than others. And I think that's reflected in some of the data you look at. And does that make sense? So it's there. So people in local authorities want it. They should be getting it hopefully next week in the SPL Plus stuff. But let me know if there's anything there, though, because I'm happy to.
Cool. I'll take a look at it. I think there's a useful debate to be had about how we all bits need to collaborate in maintaining that data together, make it useful so we can help more patients.
Yeah. And for national organisations planning, I mean, hopefully it is useful now, because this is the first time anybody can actually, outside of the NHS, can look at what the spread is across the whole country. And hopefully that's useful for looking to plan resources, charities looking across the whole country as opposed to just locally. So hopefully that's useful. But
cool. Thank you.
Fantastic. Thanks, Alistair. John, Bibby, you had a point or a question. Did you want to share that with everyone? And then Hannah Roden from Baltimore North was asking about details of who needed to be involved to do this. So that's I guess a question.
John here. No, I don't need to say anything. I've said what I wanted to say in the chat.
Brilliant. Thanks, John. But thanks for your input there. I think there's some really good points there that helps Alistair. And then the point around who needs to be able to about publishing data. I guess that Hannah, do you want to tell us why you've asked that? And then Alistair, maybe I guess streamlining the process of publishing is something that we're all interested in.
Yeah, so we've been trying to get hold of this data and publish it, obviously, anonymised for Leeds on Data Mill North for a couple of months now since it all happened and the shielded list was first released. And our IG team have just said, that point blank, no, this could not be published. MHDLG, when they shared the data with us, said it could not be used for anything else other than for us internally. So I'm just wondering whether there has been a change in policy, or what happened to allow this to be published. That we can perhaps go back to our IG team to say, could we have another look at this, perhaps to maybe publish it at ward level, because again, a figure for Leeds, it's about trying to narrow it down a bit more to communities, and where do we need to be focusing those resources. So
I'm not an IG specialist, but I'll tell you my understanding of how it's evolved, and happy to link, have a follow-on chat. So I start caveating everything I say. It's a bad habit, but so I think there's
Alistair, you're amongst friends. You're amongst friends.
It's fine. I know. I think there's so we couldn't publish it. We didn't have a legal basis of publishing until there was a COVID direction. Okay, so there was like local authorities, we're bounded by what we can do with data by our legal basis. Usually we have a basis that we, if it's in the public interest, we can publish it. Okay. Now, data that was collected, okay, because we suddenly need to go and collect a load more data, they created the COVID direction, which covered NHS Digital and some other organisations. So what that enabled us to do was go and collect the data, but it didn't have anything in there to say that you could publish it. So an amendment letter was then added 3-4 weeks ago, I can't remember exactly when that was, which said you can publish it, but you've got to follow this new process and you've got to consult all these people, and you have to be the kind of controller which NHS Digital is. So we then have to say, well, okay, you need to consult with NHSX from an operational perspective. We have to consult obviously with Department of Health, NHS England, PHE, various others, and then what that then triggered is even more reviews, and that's where we ended up with going to the Minister, going to iGuard, and going to the National Data Guardian's office to get sign off. Okay, so that's how we did it. Well, that's how it happened. So that amendment letter was actually really important, and we can then use that to publish more open data sets, but we have to follow this process. So I imagine if you're in the local authority and you haven't got that legal basis, it might be quite hard from an IG perspective, because you've got nothing to say, well, you thou shalt publish. So that's kind of the legal basis that we're going to be using to publish, hopefully, more and more COVID open data sets.
Right.
I can share the details, but I don't think that helps you particularly, because I guess you're not necessarily the controller, and you're not. I'm not sure if you've got a legal, new legal basis to disseminate COVID data.
No.
I think that's the blocker. Does that make sense?
Yeah. It does. Yeah, it does. So I guess
okay.
if we've got to wait for you to share it, how put that on the list. How
pester us, right? So Mark Reynolds, heads this up, pester us, and we'll do our best to help. Really.
Okay.
Okay. Okay. So we've got to 11:45. What we're going to do is we'll do a little blog post about data practice and some of the stuff. We don't need to go through it now. I don't want to use up people's time unnecessarily. Patrick will send a little note to people about what they can do, what they can access. I'd like to thank everyone for joining us. We're going to take a break next week, but then we'll come back with quite a technical session the week after. I think getting use cases for NHS Digital, doing something around geography, and then maybe we can add our open data practice to that session, which makes it quite a practitioner session, all about how do we use this better. And we may even have another data set from NHS Digital by then. I'm pretty sure Alistair will be working on his team to get some more. So I'm going to call it to an end here. If everyone has any points or questions people want to raise at the moment, I'm not seeing them in the chat. There's some good I think governance is, permissions and who and control is a fascinating thing that we're all bumping into at the moment. And people have realised that if they're going to address this, they do need to share, and they can't do it on their own. And that means giving up some control. It's a fascinating thing that we're all bumping into. But I think the best way to do it is remain positive, do some good things from the outside, show people how this can be done, and then they'll take that blue pill and join us on the Radically Open session. So thanks very much, everyone. We'll be in touch about Northern Lands 2. We've got a session with the ODI Leeds team about what we're going to do. We want to take some risks in doing this. We want it to be as cool as possible. We want to maybe force people to do things they're not that comfortable with. We've got a great partner in the Kingdom of the Netherlands and the embassy there. They also want to they're very pragmatic, very Dutch about this. They just want to get on and do some stuff. So I guess if you've got some ideas about how a big open thing about health data and innovation between two Northern European countries, let's think about that. So be as risky as possible, and ODI Leeds can maybe create a buffer between you and your internal politics. So we can do things, we get shouted at, and we create that little bit of a buffer between you and other people. So have a think about that. So we'll be in touch next week about what we're happening. I'm going to take a break, and we'll come back in 2 weeks' time. So thanks very much, everyone. Take it easy. Yeah, as risky as possible, Peter. Yes, that's right. Okay. Thanks a lot. Cheers, everyone. See you next time.